to do with the meaning of the pain. Okay, it's more of a psychological component to pain. Some women, for example, who are going through childbirth have reported that they really don't experience too much pain. This is not always the case, okay, but it does occur. And the reason for that appears to be not that they've got a bad nervous system or anything like that, but because it's the meaning of the childbirth experience that is acting on the suffering component of the pain experience. So you might say, well, hypnosis is a psychological treatment. Maybe it's affecting the psychological component of the pain experience. It's reducing pain, it's reducing suffering, but not sensory pain. Here's an experiment by Jane Knox, a Canadian psychologist who actually measured, because we have techniques for this, measuring both the sensory and the suffering component of the pain response in ischemic muscle pain. And what you can see for these very highly hypnotizable subjects, basically equivalent reductions of sensory pain and suffering. So it's not just a psychological treatment acting on the meaning of the pain experience. It's the hypnosis seems to be affecting both the meaning of the pain and the sensation of pain. Yeah. Yeah. Right. Yeah, this is about Ramachandran's demonstrations of actually treating phantom limb pain with this funny mirror treatment of his. There's probably no relationship between those two things. Ramachandran's not doing anything remotely resembling hypnosis with these subjects, and they're not being selected for hypnotizability or anything like that. So I think under those circumstances, you just got two different psychological treatments here. There's a tendency sometimes, and I'm not saying you did this, but there is a tendency for people to think that all psychological treatments are kind of a form of hypnosis. I've got colleagues who think about placebos as a kind of hypnosis, and they kind of say, no, that's not right. Not doing anything like hypnosis, right? It's just a pill. And here I think you've just got two very, very different kinds of treatments. It would be interesting to know what hypnosis can do for phantom limb pain. And to my knowledge, there's no such study in the literature. I think that would be a fascinating thing, precisely because, I mean, Ramachandran, with his mirror treatment, it's a psychological treatment, but he thinks it's basically rewiring the way the pain is, the way the brain is processing the pain stimulus. And it would be very interesting to see what could happen with hypnosis and phantom limb pain as well. There's a lot of phantom limb pain around, especially in VA hospitals these days. I think it's a very, very fertile ground for treatment, but for research, and I just don't think it's been done. Yeah. There's another senior honors thesis for somebody, or a doctoral dissertation, or one of you gets into medical school. Give it a shot. Here's another clinical study of pain in surgery. This is work by Elvira Lang at Harvard Medical School, who didn't use hypnosis as the sole analgesic agent in her surgeries, but used it in what physicians call an adjunctive treatment. These were patients getting outpatient surgery, an office procedure using the technique called conscious sedation, where the person is given high doses of a sedative or anesthetic drug, but still remains conscious during the procedure. Do this with propofol. You can do this with benzodiazepines. You can do it with other kinds of barbiturates. But for those of you who have had this kind of procedure, you know you remain conscious. And in this particular application of it, the subjects were actually given a button that they could push to deliver chemical analgesics to themselves. Okay, it's called patient-controlled sedation. There are controls, external controls on this. You can't kind of fly off the handle with it. But it's a very, very common technique now in medicine, in surgery. And for some of these subjects, they got a hypnotic procedure as well. They were hypnotized and given suggestions that their procedure won't won't be too painful. And what we've got here are, this is rated pain during the surgery as the procedure went on. This is a pain score on a 0 to 10 visual analog scale. And what you can see here is that the subjects who were sedated, they experienced an increase in pain as the procedure went on. For the hypnotic subjects, there was actually a significant diminution in pain. So here, hypnosis is adding something to chemical analgesia not replacing it, but basically potentiating the chemical analgesia. Here's another one. Very nice. Here you've got a patient who's kind of in control of things. They know that the hypnosis is something they're kind of doing for themselves, and there is a significant reduction in anxiety during the procedure, which is also a very nice thing to have. Medication use during the procedure significantly reduced with hypnosis. Also with this attention, there was basically a distraction. It gave somebody a video to watch or something. But here, hypnosis is significantly reducing requests for medication. And interestingly, the use of hypnosis was associated with a lower occurrence of adverse events in surgery. So there's something about these patients being very relaxed and very much in control of the procedure that reduced the number of problems in the surgery. Okay, this is all self-reports and behavior. It'd be nice. Some people say it'd be really nice to see what the brain is doing. Here's work by Pierre Rainville at McGill University, who used a variant on cold pressor pain called hot pressor pain, where you actually put the person's arm in very, very, very warm water, not scalding. It's not going to be, the arm's not going to be burned, but very unpleasantly warm. And then collected PET images of brain activity in these subjects while they were experiencing this, targeting two different areas of the brain. First, primary somatosensory cortex, area S1, which is kind of where sensory pain is processed, provides information about the location and the intensity of the pain stimulus. And he also looked at the anterior cingulate cortex, which is thought to process the emotional significance of the pain. And what you can see here, what Rainville actually did was to give a specific suggestion targeting the suffering component of pain, okay? Essentially dissociating sensory pain from suffering. And what you can see here is that the subjects experienced when they were told unpleasantness would decrease, you've got a very nice reduction in suffering without much of a change in intensity. When he looked at brain responses, you could see exactly the same thing going on in the brain. If you looked at S1, the primary somatosensory cortex, there's very little change in activity. But when you look at the anterior cingulate, you can see activity in the anterior cingulate going down when the subjects are getting the suggestion that targets the pain. So again, this is I'm spending so much time on hypnotic analgesia precisely because it's been the most studied of all of these phenomena, and it's also the most clinically useful. On a lot of grounds, it seems to be the case that hypnosis can produce a genuine reduction in pain. What about some of the other phenomena? Well, let's look at the memory phenomenon in hypnosis, known as post-hypnotic amnesia. Subjects go through hypnosis. They get a suggestion that they won't be able to remember things after they come out of hypnosis. What happens? In these experiments, subjects are hypnotized, and then while they're hypnotized, they do something completely boring, like memorize a word list. We give them a suggestion for amnesia, bring them out of hypnosis, and then test their memories in various ways. What's of interest in this line of research is testing memory twice, explicitly in terms of conscious recall or recognition, and implicitly in terms of various kinds of priming effects. Skip over these and get to an experiment done by Amanda Barnier at Macquarie University in Australia, who did the best of these studies in many ways. Here what you can see is that the amnesic subjects are showing a reduction in cued recall. That's post-hypnotic amnesia. That's a reduction in explicit memory. But when she gave them fragment completion tests of repetition priming or free association tests of semantic priming, both insusceptible, non-amnesic subjects and highly hypnotizable amnesic subjects showed significant priming effects. So here you can see in post-hypnotic amnesia, the same way we saw in organic amnesia, this dissociation between explicit and implicit memory. Post-hypnotic amnesia targets conscious recollection, explicit memory, but leaves unconscious memory, implicit memory, pretty much unscathed. I'm going to skip this one. And here's a similar study in the perceptual domain. This is by Richard Bryant, also at Macquarie University. Macquarie's got probably the most active hypnosis lab in the world at the moment. And here these subjects, these were hypnotic subjects who were given suggestions for blindness, that they couldn't see, this interesting phenomenon. And while they were blind, the hypnotist presented placards with various kinds of stimuli written on them. These were, do I have this? These were of the paradigm that you're familiar with from other experiments that I've talked about, where a homophone like peace or hair is paired with a disambiguating context word like hare and tortoise or war and peace. These were presented visually to the subjects, so they couldn't see them, right? Later on, they were asked both to recall the words that were presented to them, and as you can see, their recall was very bad. As you might imagine, no conscious perception, no conscious recall, but when asked to spell these homophones, they spelled them in accordance with the disambiguating context word that had been presented to them. So they showed a priming effect. Again, a dissociation between what we call explicit conscious perception and implicit unconscious perception. So again, the studies of post-hypnotic amnesia and the studies of hypnotic blindness suggest that we're seeing something very much like the dissociations that we see in other disorders of consciousness, with the exception that these are functional disorders of consciousness. There's no lesion in the brain that's been created here, and they are, in a sense, psychogenic disorders of consciousness because they are induced by words. They're induced by suggestions that affect the patient's or the subject's belief about what's going on. I didn't present this in this experiment, but you can see much the same thing even in hypnotic analgesia. What hypnotic analgesia does is affect subjects' explicit experience of pain, but if you make psychophysiological measurements like blood pressure or even heart rate or something like that, you can see at a physiological